So, good afternoon, everybody. I will continue today on the lecture about mortality. But just before I start talking about it, just to have an overview of the last activities that we're going to have until the end of the semester. So, today we'll have quiz 13, and it's going to be about the mortality chapter as these previous quizzes. Assignment 2, last semester, I gave it more towards the end of the semester, but now it's not. And I was going to make it about migration, but since we will not have it covered by this coming Thursday, I will make it about fertility and mortality. Probably more about mortality. That has been a more controversial topic now, but I have to think about it. And then assignment 3 is going to be about migration. So assignment 1 was more general about population growth, the negative and positive effects about it. And all of them technically are worth 1 point. Anything above 1 point is extra points. So assignment 1 has 2 extra points. Assignment 2 has 2 extra points, and assignment 3, 1 extra point. So 5 extra points in total throughout the semester. And I will post the grades for assignment 1 before Thursday, so you have an idea of what I'm expecting, and then I'm going to post assignment 2. And as I did for the first assignment, I will give you more time. So I give you the whole weekend from Thursday and then until Monday to submit assignment 2. And the same thing will be for assignment 3. Since they are more open essay, you're going to have more time to answer the question. And it's going to be the same style. You answer it write in a Word document, or just do a Google Doc and then save it as a Word document and upload it within Canvas. And for the other classes, we're going to have regular quizzes. And 1 week from now, we are going to have exam 3. And it's going to cover mostly migration and, mortality. That's what we cover more after exam 2, but the exact content of exam 3 I will inform on Thursday. And then we will continue. And as I said, because of the winter storm and everything, I'm planning to at least cover the migration chapters, and probably we're not going to cover in detail all these other chapters, okay? And the lecture about mortality, we covered up to the portion about mortality trends and differentials in the world. And then now I will start talking about mortality and longevity in the US. And then continue on infant mortality and the coronavirus pandemic. I did update, even today, some slides about the pandemic that I will show throughout this lecture. So, and I already uploaded it to the course website, so you can download it again if you want. So mortality in the US started dropping gradually in response to changes in socioeconomic conditions in the country that start to get better, and overall modernization of the country. And much of the mortality reduction started to happen before the initiations of any appreciable public health measures. It was more related to economic development and overall improvement in the life standards of people. And the countries that first experienced mortality declines, such as Western European countries and the US, the drop happened a little slower. They were the first ones. And then afterwards, when developing countries in Asia, in Africa, in Latin America started to experience drops in mortality, they experienced faster drops in mortality, exactly because they start to import a lot of technology and knowledge from developed countries. But In developed countries such as the US, the mortality dropped gradually over time. And just to give an idea, it dropped gradually, but between 1900 and 2013, mortality decreased throughout all these decades, and it dropped from 46 years of age, the life expectancy for males, to 76 years of life expectancy in 2013. So the average number of years that men were expected to live with data from the 1900 was only 46 years. It increased to 76, which means a drop in mortality. And for women, it improved from 48 to 81 years of age. Most improvements happened from 1900 to 1950, control of infectious and parasitic diseases, basic measures that people start to implement, boiling bottles of water and milk, washing hands, protecting food from flies, isolating sick children, ventilating rooms, improving water supply, and implementing sewage disposal. And since the 1950s, life expectancy improvements is due to the prevention and control of chronic diseases. So between 1900 and 1950, mortality declined, and mostly because the incidence of infectious and parasitic diseases declined over time. After that, you start to have a control of more chronic diseases, such as heart disease and stroke. As we talked in the previous class, the epidemiological transition, we move from a moment in which you have really high incidence of infectious and parasitic diseases that affect with higher incidence young people, children. Those start to decline, that incidence, and then you start to have a higher incidence of chronic diseases. But then as we have more medical advancements in our society, we start to control those as well. In the US specifically, when we are talking about mortality, we always discuss the Hispanic Paradox, or more specifically, the Hispanic Epidemiological Paradox. What exactly is this? It's pretty much the empirical finding that Hispanics have death rates of about the same magnitude and sometimes actually lower than the non-Hispanic white population. And this Hispanic paradox is also known as the Latino mortality paradox. And these findings are more evidence for those people with Mexican origin. So the main point is here, you have the Hispanic population that overall, they have lower socioeconomic status than the non-Hispanic white population, but they actually have similar levels of mortality, or in some cases, they have even lower levels of mortality than non-Hispanic white population. So that's a paradox because the overall group of Hispanic people or Latinos, they have worse socioeconomic status than the white population, but they experience the same average number of years of life, if we are talking about life expectancy. But these findings are not so straightforward. There are different explanations of why we see this better health than expected among the Latino population. And that more positive effect is usually more concentrated among immigrants from Mexico. So just to give you here an overall idea of these levels of mortality, or in this specific case, using the indicator of life expectancy at birth by race ethnicity from 2006 to 2011, and broken down by both race ethnicity and sex. So the Hispanic female population has the highest levels of life expectancy, in other words, lowest levels of mortality. Non-Hispanic white women, second group, and then the Hispanic males, non-Hispanic Black females, non-Hispanic white males, and non-Hispanic Black males. So if we control for sex and we just compare Hispanics to non-Hispanic white people. So controlling women to women, Hispanic have higher levels of life expectancy at birth than non-Hispanic white women. Comparing man to man, Hispanic and white, Hispanic men have higher life expectancy at birth than non-Hispanic white men. So overall, you have this pattern of Hispanic, white, and Black in terms of higher life expectancy at birth, which means lower mortality among the Hispanic population, white in the middle, and then the Black group below the white. And just talking about these three race ethnicity groups here. But this is just to show that overall, we would think that the Hispanic population would have lower life expectancy at birth than the white population, but that's not observed, taking the group as a whole. The only thing that we are controlling here is by race ethnicity itself and by sex. And controlling only those people with the same sex, you always say Hispanic above the white group. And this figure is shown exactly in our textbook. What are some of the reasons, or what are the possible explanations about why we see better life expectancy at birth among the Hispanic population compared to the non-Hispanic white population? There are three major groups of explanations: methodological effects, migration effects, and cultural effects. Maybe actually this better life expectancy at birth or lower mortality among the Hispanic population is actually due to measurement error. Maybe there is underreporting of the Hispanic origin identification on death certificates. Maybe people die of Hispanic origin and their deaths are not reported to the government, right? And it's not reported to the local government, to the state government, and to the national government. As we talked about, local governments, they collect this information and then we get it transferred to the state level, and the state level sends it to the national government. Maybe there is a misstatement of age, perhaps an overstatement at older ages. People reporting the death of their relatives and they overstate the age of their relatives. So in these two cases here, these are pretty much methodological issues, data issues. The first one, people not reporting that they are dying. So you count less people in the numerator of the formula of the migration of the mortality rates. A misstatement of age is that you are reporting the age in which the person is dying in an incorrect way, and then you are saying that the person is older than actually the person was when the person died. Some other explanations are related to migration effects. Maybe there is a healthy migration effect. Whenever we talk about migration, and we're going to talk this, we already talked in previous lectures, and then we're going to talk again in the next chapters. Migrants, people who decide to migrate, they have specific characteristics. And due to these individual characteristics or family characteristics, these people are more likely to migrate. So that's what we call self-selection of immigration. So maybe exactly those people who have better health, both physical and mental health, they will be more likely to migrate because it's such a hard journey and so complicated, so difficult to migrate from one country to the other, even with visa all documented and everything, that it's only those people that are healthy, are better off, and in this case, even have better socioeconomic status compared to their origin, to those people in the country of origin, they will be the ones more likely to migrate. So people that are usually more better off compared to those in the country of origin and also are healthier, they tend to migrate more. And because of that, they will have better health outcomes when they come to the US. And there is also the hypothesis, the Simon bias hypothesis, with the idea that maybe some Mexican Americans in poor health, they return to Mexico at older ages and then die in Mexico. So they do not enter in the numerator of the mortality rates in the US because they will live, they maybe want to live their last years in their home country, and they die in Mexico and they're not counted as dying in the US. And that might have an effect on the lower mortality rates among Mexican Americans. And this Simon bias with the idea that Simons, they migrate back to die, and here it's really related to return migration. So there is an effect on self-selection of migration, but it could also have the effect of return migration could be one of the reasons that we see lower mortality among the Hispanic population, and more specifically among Mexican Americans. And another set of possible explanations is related to more cultural effects. There are better dietary practices of Latinos, less consumption of fast food, for example, like as is usually more common in the US, and stronger family obligations and relationships creates a more stronger social network and people helping with each other, both within the family and the community. But there are also studies showing that first generation immigrants, those that are born outside of the US and then moving here, they tend to have better dietary practices than people born in the US. But the children of immigrants experience all the American culture, so they will tend to eat and to behave as Americans, and then this positive effect of having a better diet disappears, starting on the second generation. Right? The second generation is pretty much American, and is American, and they tend to integrate and assimilate all these cultural behaviors of the American society.
Because we're all fat.
What's that?
Because we're all fat.
Yeah, and that's related to increasing obesity as well. Like we talked before in the previous lecture, that in the past, centuries ago, the poor people would tend to be skinny because they would not have access to food. But then in our contemporary society, the poor people, they will have worse diet, eating more fast food, high cholesterol food, and then they would be more likely to become obese, right? Another important topic to discuss in mortality in the US is the racial crossover. The life expectancy at birth is the lowest for Blacks compared with Hispanics and whites. We saw that in this graph here. Black woman, lower than white woman, lower than Hispanic woman, life expectancy. Black man, lower than white man, and lower than Hispanic man. So overall, life expectancy at birth is the lowest for Blacks compared to Hispanics and whites. And for most of their lives, Blacks have higher death rates than Hispanics and whites. So pretty much here, this first topic is talking about life expectancy at birth. But we saw in the life table that we can estimate the life expectancy at all the other age groups. Even in other age groups passing through adult ages and everything, Blacks usually have higher death rates than Hispanics and whites. But the situation changes at very old ages. By late life, death rates for Blacks become lower than those for whites, and in some cases, lower than those for Hispanics. So Black population usually have lower life expectancy, higher mortality than these other groups. But then when you reach those last rows of the life table, people at really higher ages, the remaining years of life that we see in the last column, usually the last column in the life table, is higher among African Americans than other groups. And here's an example. So just remember our life table. Our life table, we have the rows representing the age groups, right? 0 to 1, 1 to 4, and so on, until 80 to 84, 85 to 89, and 100 plus. Here in this table, we are showing the last 3 rows here. And in this case, from 70 to probably 70 to 79, 80 to 89, 90 to 99, and 100 plus. And we have this information by sex for men and for women, and also broken down by race ethnicity: Hispanics, whites, and Blacks, non-Hispanic whites and non-Hispanic Blacks. And this is data from 2010. So all these people were born, and usually the Blacks, they have lower life expectancy because they have higher mortality. But then when we start reaching older ages, that is the opposite. So for example, how do we interpret this number here? Hispanic males, considering data for the US in 2010, they have chance of dying before reaching age 70. But once they reach age 70, we expect them to live another 15.4 years on average, in addition to 70. So we expect them to live 85.4 years on average. Men, Hispanic. Women, 18. So once they survive the chances of dying previous years, they reach age 70, they're expected to live an additional 18 years on average. In other words, reach at least 88 years of age on average. And you see that's lower, comparing among men only. It's lower among white men than Hispanic men. And it's also lower among Black men. So even when they reach at age 70, the additional years that we are expected to live on average among Blacks is still lower than the other groups. And the same thing happens for women, 18, 16, 15. By age 80, 9, 8.1, 7.8, still lower among Blacks, 10.8, 9.6, 9.6. Now here among women, you start to see similar levels. And then you have the crossover. 4.5 Hispanics, 4 whites, and African Americans here, they pass whites, 4.4. 5.4, 4.8, and 5.2. Women now expected to live more than Black women expected to live more than white women. And then in the last group, 2.3, 2, and 2.5, higher. 2.6, 2.3, and 2.8, also higher among African Americans. But of course, it's really, really at high ages. So it shows that the issue of higher mortality among the African American population, it's real in the US, that any racial crossover happens only at really high ages, okay? What are the possible explanations of this racial crossover? The same thing, the possible explanation about the Hispanic paradox. Maybe there is methodological issues, data issues. Maybe there is age misreporting on death certificates. The same way for Hispanic population, maybe there is some overstatement of the age that African Americans are dying. But this would only postpone the crossover to later ages. We would not actually eliminate it. And there is also population heterogeneity in frailty. Maybe the surviving elderly Black population is a more robust group among the disadvantaged individuals. Overall, the African American population, for historical factors, have lower socioeconomic status, have lower levels of education attainment, have higher levels of segregation, even in usually more disadvantaged neighborhoods. And that affects all this population. And maybe those surviving to really old ages are a selected group among this more disadvantaged group of individuals. Maybe the more frail Blacks, the more fragile Blacks, they die before the age of 80 or 90. And this produces a more robust group of Blacks that live at longer ages than the majority of the population. Right? But again, that's not a positive thing per se, because it's just showing that still we have this negative or this really huge inequality mortality by race ethnicity in the US, and is related to historical factors and lower opportunities for the Black population. That affects their income, that affects their education, that affects their health and their mortality. And this graph here is just interesting for us to understand causes of death by age. The percent distribution of 5 leading causes of death by age group. Data from 2011. Whenever you ask young people what you think is the most possible causes of death that they would experience at their current age, they might give you explanations like terrorist attacks and these kind of things that are reported more in the media. But the data shows that 38% of people aged from 1 to 24 in the US, data from 2011, die because of accidents, 13% homicide, 13% suicide. So more external causes. And then as people get older, more chronic diseases start to take the lead. So cancer, heart disease increases among people 25 to 44, get even higher percentage between 45 and 64. And then among 65 plus, heart disease, cancer, chronic lower respiratory diseases, stroke, Alzheimer's, and other causes. But just shows the increase on chronic disease among people of older ages and a decline on these causes related to external factors. And now we enter on the topic about infant mortality. Infant mortality is a major topic whenever we are discussing changes in health and mortality over time in the populations. And as we talked before, when we were discussing the life table, infant mortality is really important to understand that specific chances of people dying before reaching age 1, that in the life table, we have a separated row for that group, people below 1 year of age. So the infant mortality is the most common measure of infant death. We're pretty much in the numerator, we count how many children die before reaching age 1, and then in the denominator, we put how many children were born in a specific year in a specific country, and multiply that number by 1,000, otherwise we would have really small numbers in terms of decimal cases. Declining infant mortality is key to population growth. We already talked about this since the demographic transition theory. That graph of the demographic transition theory, we see fertility and mortality are really similar to each other. Population growth, it's low because we have a lot of births, but a lot of people dying. As mortality starts to decline, and mostly of the first declines in mortality is due to declining mortality among children, and fertility is still high, then the natural increase, this difference between births and deaths is really high, births minus deaths. And this difference here is natural increase, and it generates population growth in a society. After a while, more fertility also starts to decline, and then we have a slower population growth than in previous decades.
Is that calculated, the under age 1 per 1,000, is that calculated at the point of birth, or is that at the point of conception for infant mortality?
Birth.
Age birth.
Birth. So if someone is born in March 31st, that person will can be counted up to March 30th in the next year.
So that's the difference between neonatal, or is neonatal still birth?
It's still birth. All those are still birth. Neonatal, it's more related to death really at the first days of age. And we're going to talk about them in the next slides.
I read it.
Yeah, no problem. Like here, we are talking about deaths after birth, not conception, right? Why we saw these changes, these declines in infant mortality in these last decades, in these last centuries? The reduction is due to the development of oral dehydration therapy, pretty much a simple solution of salts and sugar taken orally that we can make by ourselves at home. We can buy in a drugstore, in a grocery store, anywhere. It treats diarrhea, which is a major cause of death in young children. And it was developed in labs, and it was tested in the field, and especially in Bangladesh, that had really high levels of infant mortality. And actually, one of its founders still holds a teaching position in Harvard School of Public Health, Dr. Richard Cash. So that's really recent changes, really significant drops in infant mortality were due to actually recent therapies that were developed in these last decades. Infant mortality, there is a lot of variation across countries in the world. So Sierra Leone here in this case, 117 deaths of children before they reach age 1 per 1,000 births, according to data from 2015. Chad, Mali, Nigeria, Afghanistan, Pakistan, Ghana, all really high levels of infant mortality. And then you get like Egypt, North Africa, Mexico, China, Russia, US, Canada. You start to see much lower levels of infant mortality. And so you have an idea, based on data from 2015, the average infant mortality rate was around 37 deaths of children before reaching age 1 per 1,000 births, per 1,000 live births, right? Just to show that there is still a lot of variation of infant mortality across countries. Here are the countries with the highest infant mortality rates and the lowest infant mortality rates. Pretty much just showing specific countries: Central African Republic, Congo, Democratic Republic, Chad, Angola, Guinea-Bissau, and Sierra Leone, really high levels. While you have on the other hand, Iceland, Finland, Japan, Singapore, Estonia, and Sweden with really low levels of infant mortality compared to these other countries. And that's data from the Population Reference Bureau. The Population Reference Bureau is one of those links that I put in the course website. They have a really nice data website that you can collect information, and it's usually information that you can compare across countries. And here, it's infant mortality rate for several countries, but then broken down for the US for specific race ethnicity groups. This is just to show that there is a lot of variation in mortality across race ethnicity groups in the US. So you see infant mortality rates, and this is data for 2018, 2019, high in India, South Africa, Indonesia, Colombia, Mexico, and Brazil. And around that same level, you have African Americans. So 11 deaths of African American babies before they reach age 1 for every 1,000 live births of African Americans, according to data from 2018 and 19. American Indians also around the same levels, and then Pacific Islanders get better levels and more similar to the levels in China and Chile. The Hispanic population in the US have overall the same similar infant mortality levels as the US population as a whole, and around the same as Russia, the Slovak Republic, and Canada. US, the white population, little lower infant mortality than the Hispanic, and the Asian population even lower, which means that they are much closer to those countries with really low levels of infant mortality, European countries, France, Poland, Denmark, Greece, Netherlands, and so on. This is just to show that within the American population, this orange bars here, we see a lot of variation in terms of the levels of infant mortality. Shows that if you want to tackle the issue of infant mortality in the US, you have to deal with specific groups that are much more likely to die than others. If you compare African Americans to, they almost like more than like around 4 times higher than infant mortality. 3 times higher than the infant mortality of the Asian group. Like if it's here around 4 and he's around 12, okay? And this is per year, and looking only in the US, infant mortality rates by the mother's race ethnicity from 2000 to 2010. And you still see really high levels among the Black population of infant mortality, and kind of dropping over time, but it's still really high differentials compared to the white population, the Hispanic. And the white and Hispanic kind of similar, which we also saw in this graph here, 5.1 and 4.7, also really similar here among the white and Hispanic, but the Black population really much higher levels of infant mortality. And now what Aaron was asking, neonatal and post-neonatal mortality rates. The infant mortality rate may be thought as the sum of 2 mortality rates, the neonatal mortality rate and the post-neonatal. The neonatal mortality rate are deaths of babies aged 18 days or less. So babies that die in the first month of age, the first 4 weeks, right? And post-neonatal mortality rate, deaths of babies aged between 29 days and 1 year. And both of them we also multiply by 1,000, otherwise these rates would have a lot of decimal cases, difficult to interpret. And just to show here some variation across the world in terms of neonatal mortality rates. And these are the overall deaths per 1,000 babies. So these are rates in 1990 and 2013, and then showing the decline over time. Developed countries declined from 8 to 3 of babies dying the first 28 days of life, and declined 55% between those years. In developing regions, declined from 36 per 1,000 live births to 22, decline of 40%. And this decline happened differently within all these groups here within developing regions. And for example, the regions that had really high levels of mortality, of neonatal mortality at the beginning of the period, like Northern Africa, 30 to 13, it experienced a huge decline in terms of percentage change. Sub-Saharan Africa, on the other hand, was even higher than Northern African countries. It did not decline so much. It declined to 31 deaths per 1,000 live births in the first 28 days of age, a decline of 32%, lower than the 56% in Northern Africa. So you still see a lot of variation. In Eastern Asia, huge improve from 25 to 8 per 1,000 live births, 69% decline between 1990 and 2013. And these are the absolute numbers in thousands, just to show how still there are a lot of babies dying in the first 28 days of life, right, before reaching 29 days of age. And in developed regions, among 4.5 million in 1990 to 2.7 million in 2013. In Southern Asia, exactly because of the overall population being high, from 1.9 million to 1.0, or from to 1.1 million here. And the same thing that we did for the Hispanic Paradox discussion and for the racial crossover, here we try to understand what are the reasons why these babies are dying in such young ages. And in this case, it's going to be clear about the endogenous and exogenous causes of death. Endogenous causes of death in an infant can occur because of genetic issues or conditions associated with fetal development or the birth process. Exogenous causes of death is due mainly to environmental external causes, such as infections or accidents after the baby is born, is exposed to these infections, and then the baby dies. Endogenous causes are more related to genetic issues and to conditions related to fetal development. Okay? For neonatal deaths, what are the main causes of death? They are mostly related to endogenous conditions: congenital malformations, chromosome abnormalities, complications of delivery, low birth weight, and genetic disorders. Endogenous causes dominate infant mortality mainly in the early days of life, and not for the entire first month of life. So we are talking about the neonatal and the post-neonatal. The neonatal is the first month of life up to 28 days. And even within that interval, the endogenous causes, they are more prevalent in the first days of life of the baby, and more related to all these different factors that are listed here. The causes of post-neonatal deaths are usually due to exogenous causes. And the post-neonatal mortality rate was 18 per 1,000 live births for the world in 2013, just for you to have an idea, because that previous graph I just showed the neonatal deaths. And a lot of variation, 18 in the world and only 2 deaths in developed countries per 1,000 live births between 29 days and 1 year of age. Deaths in post-neonatal period and in the first few years of life are mainly due to exogenous causes, so infectious causes, accidents, and injury. In this case, improved life standards, better health care, and public health measures, they have greater effects on exogenous causes than on endogenous causes. Endogenous causes are more related to genetic issues, more related to biology. Exogenous causes are more related to the environment, where people live, the conditions in which the child is being raised, right? And stillbirth or miscarriage and fetal deaths. A stillbirth is a fetus not born alive and is not registered as a death. So Aaron, this case here is that this fetus was not born alive. In the previous rates that we discussed, they are born alive, and then we see if they died before reaching 1 year of age. If it's before 29, up to 28 is neonatal. Between 29 days and 1 year is post-neonatal. Stillbirth rate is a fetus not born alive, and it's not actually registered as a death. And how is calculated the stillbirth rate, the SBR, is stillbirth divided by live birth plus the stillbirth. So the denominator of stillbirth rates is different than the previous ones. What was the denominator of infant mortality rate, neonatal mortality rate, and post-neonatal mortality rate? The denominator of those previous ones were only live births in the denominator. For stillbirth rate, we have live births and stillbirths in the denominator. In the numerator, we count stillbirths. And the same way as we did before, we multiply by 1,000. Stillbirths are often identified in hospital reports dealing with obstetric procedures, but in terms of measurement here, it's important is that the denominator of stillbirth rates includes stillbirths, fetus not born alive, while infant mortality rate, neonatal mortality rate, and post-neonatal, the denominator is only live births. Okay? The World Health Organization mentioned that interventions can be planned if we know at what point before birth the fetus died. So some interventions in terms of public health can be implemented in the population in order to avoid this problem. And it's still a big problem in the world. Around 2.6 million stillbirths were measured in the world in 2009. And the overall rate was 18.9 stillbirths per 1,000 live births and stillbirths in the world. Okay? And the perinatal mortality rate relates to stillbirths and deaths of babies who live for only 7 days or less per 1,000 live births plus stillbirths in the year. So the perinatal mortality rate does include in the denominator, the same way as the stillbirth rate, live birth plus stillbirth. In the denominator of the perinatal mortality rate, we have both live births and stillbirth. In the numerator, we have stillbirth plus deaths of babies who lived only for 7 days, first week or less. Endogenous causes of mortalities in the first week after birth are similar to the causes of stillbirth. It's more genetic conditions as we talked before. The perinatal mortality rate in 2010 were 47 stillbirths or deaths of babies in the first week per 1,000 live births and stillbirths. And it varied a lot in the world, 10 per 1,000 in developed world and 50 in the less developed countries. A lot of variation across the world too. Czech Republic and Singapore only 4, Mauritania 111. The US, it declined over time, but because the level is already small compared to other countries, 6.5, it declines to 6.3 between 2006 and 2011. Another measure important for mortality is maternal mortality ratio. Maternal mortality ratio measures the extent to which mothers die immediately before, during, or after giving birth because of problems associated with the pregnancy or childbirth. So what's the numerator of this ratio? Number of deaths in a year of women dying because of complications of pregnancy, childbirth, and puerperio, which is the condition of the woman immediately following childbirth. So it can be during pregnancy, childbirth, or after that. What's the denominator? The number of live births occurring in the year. And in this case, we multiply by 100,000 instead of only 1,000 because this ratio is rare in several countries. Why this indicator is called a ratio and not a rate? We discussed the difference between ratios and rates at the beginning of the semester. In the rate, or in rates, the denominator, we count people who have the risk or have the chance of experiencing the event that's being measured in the numerator. Ratio, we are comparing two different groups. The denominator doesn't go to the numerator. Sex ratio. What is sex ratio? Number of men divided by number of women in a specific country in a specific year. Right? This group doesn't go to the numerator, doesn't have the risk of going to the numerator. In this case here, maternal mortality ratio. The numerator is number of deaths of women because of pregnancy, childbirth, and so on. The denominator is number of live births, children. So we are comparing women dying because of childbirth, complications in pregnancy, and so on, comparing to the number of births in the denominator, the live births. So that's why it's called a ratio, not a rate. Oh, it's really small problem in the US, for example, because it's a developed country. Not really. There is a professor here in the sociology department, Professor Teresa Morris, and several other researchers and professors in the School of Public Health as well, that are concerned about maternal mortality ratio differentials by race, ethnicity in the country. There is a lot of, the incidence of maternal mortality ratio is much higher among African American women than among other groups, right? So it's still a concern. And in states that there is less regulation of health services to the population, the more vulnerable population don't get access to prenatal care or to good quality at the childbirth. And then there is a higher chance of women dying because of issues during the pregnancy, childbirth, and conditions after childbirth, right? Exactly because of lack of adequate prenatal care and so on. And that's a huge problem still in the US with considerable, significant variations by race ethnicity. Some examples of maternal deaths. In the world, there were around 529,000 maternal deaths in 2000, and it dropped to 313 in 2015. Developing regions, they had pretty much like 99% of all maternal deaths, 66% concentrated in Sub-Saharan Africa, and 21% in Southern Asia. The maternal mortality ratio in 2015 was 2016 deaths of women due to these conditions of issues in pregnancy, childbirth, or right after childbirth per 100,000 live births. Much higher levels in Sierra Leone, also high levels in Sub-Saharan Africa compared to, for example, US, Iran, and Hungary, and low levels in Greece, Singapore, and Estonia. So a lot of variation in terms of maternal mortality ratio across countries. Factors associated with maternal mortality ratio, maternal deaths are mostly due to age, parity, and birth space. So age. Younger and older women are more likely compared to women in their 20s and 30s to die because of issues in pregnancy, childbirth, or right after childbirth. In terms of parity, what is parity? The overall number of children that women have. Women that have a lot of children are at higher risk of dying due to issues in pregnancy, childbirth, and right after birth. birth spacing. Women who have children right one after the other, not as much space between them. In other words, women with short birth intervals are also at higher risk of dying due to these issues. Other factors: chronic disease and malnutrition, poverty, unwanted pregnancies, and what I mentioned before, inadequate prenatal and obstetric care, and lack of access to a hospital are all associated with maternal mortality ratio. Well, and now the last portion of the chapter related to mortality, the author discusses some future causes of mortality. Is it likely that mortality rates will continue to fall, resulting in even higher levels of life expectancy than those attained by developed countries in contemporary societies? So that's a major question that demographers and public health researchers try to answer. And there are pretty much two major answers to this question. One group argues that there is a limit. We cannot actually improve life expectancy forever. And another group that argues that there is not actually a limit, and societies as we develop, we will keep living longer on average. And Poston argues against. Poston is the Dudley Poston, the author of our textbook, argues against a fixed biological maximum life expectancy. So he has this more optimistic view that argues that there is no biological limit for the average number of years that we live. We will keep improving life expectancy. So mortality will keep declining in his point of view. Modern medical and public health techniques will surely bring about further reductions in mortality from the major causes. However, there is also evidence since the early 1980s of mortality reversals, first in Eastern Europe and later in Sub-Saharan Africa. I'm going to talk a little bit about them. And of course, now we are living in the pandemic. We see that some techniques, some technologies, as we discussed before, they developed a lot in this last year. You would never expect that we would be able to have vaccines from so many companies developed within a year for this new disease. And just to show that if there is this huge effort in order to improve medications and health measures, we can still improve it. But the pandemic is causing a lot of deaths, and that can, in the short term, generate drops in life expectancy in several countries. And some other examples we're also observing in these other parts of the world. So in Eastern Europe, for example, what is causing mortality reversals? In other words, mortality increases in Eastern Europe. And this is not related to pandemic, this discussion here. This book was published in 2017, right? So this increases in mortality in Eastern Europe, it's before the pandemic. Possible factors that might be the reasons of increases in mortality in Eastern Europe: lack of preventative health programs, inadequate quality of medical service, smoking and alcohol abuse, and general neglect of individual health. And these are what we would say the proximate determinants of mortality, those factors that are close to the reasons of mortality. And what are these more indirect factors that cause the proximate ones? Lack of life choices under the former communist regimes, and more recently, unemployment, relative deprivation, and inability to cope with economic challenge of the capitalist regime. So all these economic changes that these countries face, these general socioeconomic changes, or how the society was organized before, make people change all these different factors here, which, like I said, would be, so we make a parallel to fertility, would be the proximate determinants of mortality, for this specific example, causing increases in mortality. The second example in the book, Sub-Saharan Africa, the AIDS epidemic has halted or reversed gains in life expectancy in many of the Sub-Saharan African countries. So it's still a major issue. So that's why there are so many researchers trying to deal with the AIDS epidemic, specifically in Sub-Saharan African countries. Degenerative diseases are the major causes of death in the developed world, as we talked about, cancer, heart disease, and so on. Future improvements in the treatment of these diseases is likely to happen. We are always improving and finding new technologies. However, even if we eliminate, there are some private companies, private hospitals that mention, oh, let's eliminate, let's eradicate deaths caused to cancer. But even if we eliminate specific degenerative diseases, it would result in a small increase to life expectancy because these diseases happen to older individuals. So maybe individuals, instead of dying at ages 80, would die at 85, or instead of 85, 90. Still, there is improvement because we are eradicating these degenerative diseases, but overall, the life expectancy doesn't increase as much. For example, eliminating heart disease would raise life expectancy in the US by 5 years, and eliminating cancer would raise it by only 3 years. But of course, it's important. Of course, it's important to look for treatments for these diseases, right? An important question that he asked in the chapter is, the important question is not will life expectancy increase? The important question is by how much will life expectancy increase? So what's the pace in which we will increase or experience some decreases as we have been seeing in Eastern Europe and Sub-Saharan African countries? And now, because of the pandemic, we're gonna see some declines in life expectancy in several countries as well. And then here, just giving you an update about the pandemic. This is, I just got data from Worldometers in the coronavirus page. And here I just sorted by countries in terms of total deaths. And this is data that I collected in August 24th, 2020, at the beginning of the previous semester when I was teaching the same class. The US first, Brazil, and here I show up to the 20th country, sorted by total deaths. January 19 was when I first showed you at the beginning of our semester this year, 2021. The US jumped from 181 deaths to 408,000 deaths. 881,000 to 408,000. And Brazil also with really high levels, 210,000. And this is data that I collected last Thursday, on April 1st. The US reached 565,000. And as we talked before, like at the beginning of the semester, we were at 400,000. And the CDC was already expecting another 100,000 deaths by 1 month. And that's what we saw. By February, the US reached 500,000 deaths. And then last week, 565. And there is some variation here from the top 20 countries, but Brazil also really high up there. And these are the overall number of deaths. And we can calculate a series of different measures, total number of cases, new cases, total deaths. If we get total deaths divided by the population and multiply by 1 million, we have death rates by 1 million people. Total cases divided by the population, multiply by 1 million, total cases by 1 million people. Tests by 1 million people for every 1 million people. And yeah, so this, and this website is always changing the columns that they show. Focusing on the US, and this is data collected by Professor Philip Coyne, the Department of Sociology at the University of Maryland. I already mentioned to you, I usually get he has been reporting, he has been collecting data about the pandemic from different sources, from the CDC, from the New York Times, from all these different sources, and he's compiling this database and made a database available for free for anyone to collect. I follow him on Twitter. That's why I usually get these graphs from him. And these are COVID deaths per 100,000 population in the US, but broken down by race, ethnicity, non-Hispanic Black, Hispanic, non-Hispanic Asian, non-Hispanic White, and also by age group. Older people more likely to die than younger people in all race ethnicity groups. But when you control by age, only the older people, Black people, more likely to die than the other groups. People between 75 and 84. Blacks and Hispanic more similar and much higher than the Asians and whites. 65 to 74. Blacks and Hispanics similar, Asians and whites lower. And of course, younger people between 30 and 49 with lower chances of dying. Whenever we talk about the COVID pandemic, we get information, oh, but the pandemic is not killing as much, or is killing as much as the flu season. And if you just look at data, that's not what's happened. This is data only for the US. From the CDC, you can go to this website here. The data for 2017 until 2020 is still estimated, so it can change still. But overall, the number of annual deaths due to the flu is much, much lower than the US experienced up to December 31st, 2020. So deaths in 2020 in the US due to COVID-19, 351, and this data from our world in data. And I got this data here, right? So I made this graph. I think the original graph was done by Philip Cohen, Professor Cohen, but I think he did it up to September, and that was already much higher than these numbers here. So I just updated to December 31st, okay? And these are a similar graph that I showed to you guys before at the beginning of the semester. New cases, just linear to see how new cases of the pandemic increased and then has been declining more like in 2021. Like after January, and now you start to see more people getting vaccinated and social distancing, wearing masks, and that has an overall effect on declining the cases. But you still see some back going up. And I mean, we see like here in Texas, in March 10th, where pretty much the governor opened everything, and you might have some increases within these next months or weeks. These are new deaths. We experienced the first wave in April last year, and then summer last year, and then around right after Thanksgiving and Christmas this last year as well. Number of deaths, and this is data again that I updated from last Thursday, April 1st. Data from this data here was from Our World in Data, and this one here is from the New York Times. And here reporting data on number of cases in the US and number of deaths. And what's interesting is to kind of put these two graphs together to see this. These lines, I just put them here. Exactly when you see an increase in the number of cases, around 2 weeks later, you see increases in deaths. Increase in cases, increase in deaths. Increase in cases here in red, increase in deaths in black. Same thing even in this year with data from January, right? So there is no magic here. If you see an increase in cases, after around 2 weeks, you start to see an increase in deaths due to coronavirus, due to COVID-19. This is for Texas specifically. You also saw that last summer, increase in cases. A couple of weeks later, increase in deaths, increase in cases early this year, increase in deaths around early February, right? And now the cases kind of like declining, but it's still a considerable amount of people having it, and a considerable amount of people still dying due to the to coronavirus. This is data from the New York Times as well, back from October, the middle of my previous semester when I was teaching this class. These are average daily cases per 100,000 people, so it does take into account the size of the population in all these counties. Much more concentrated in the eastern half of the US than the west part. And then from January 19, at the beginning of our semester, pretty much spread out all over the country. And from last week, Thursday last week, these rates kind of decline a little more, and probably related to exactly vaccination increasing, social distancing, masks, and so on. And looking for the specific case of the US, also in the middle of my previous academic semester, October 21st, higher incidence of cases taking into account the size of the population in eastern Texas, and January pretty much spread out all over the state, and data from last week kind of dropped down, okay? Yeah, in these shades here, it's always difficult, but I think they're all in the same scale, right? This is data that you have to collect exactly at those dates. And this was data from college coronavirus cases. And the latest updated is from December. So this one was from October 21st. So here at Texas A&M, we had 1,661 cases. And then in December, 2,767 cases. And if you go back to this website, at least last week, I looked at it, that was the latest update, December last year. These are some resources where you can get further data, and where I got some of this data here for this lecture. For example, I used a lot from Our World in Data. Also, Worldometers, the table by countries is the Worldometers website. And the graph for the US, and you can select other countries, Our World in Data. And also a lot of information from the New York Times, but you also have this community vulnerability map, and also data from Johns Hopkins University. And some resources more specifically linking coronavirus to demography, how it varies by age, by sex, and by several other characteristics. The Population Europe has this website that they are pretty much, it's a repository of several different studies done across the world, kind of linking the coronavirus pandemic to demographic factors. And so here, kind of like showing Italy experienced high death rates because of having a population that's has a higher percentage of people in older ages, but also there is some of the discussion here shows differentiated by sex, and then by race, ethnicity, and so on. And Dudley posted the same. He wrote this op-ed back in March, kind of when the census, the 2020 census was going on. Some of the students that left, for example, College Station, to go back home after spring break because the university closed and everything went online after spring break 2020. Some of these people did not answer the 2020 census. That could undercount the number of people living here in College Station and other college towns, and then they will be affected by receiving less government funding in the coming years. So that's a discussion that he makes there. Association of coronavirus and sex, so this is very specific about that, of coronavirus killing more men than women. coronavirus in politics, showing that usually more authoritarian countries were the ones dealing the worst with the pandemic. And that's the case of Egypt, and that's the case of Brazil with a new fascist president that we have there right now. All that kind of showing that public health and politics, they are really related. In this case, more authoritarian governments have deal worse with public health issues. So those are the references. So I finish here the chapter about mortality. In the next class on Thursday, by then I will have posted the grades for assignment 1, and I will make assignment 2 available, which you have up to Monday to answer and to upload it to Canvas. And I will start on the internal migration chapter on Thursday. Okay? So thank you very much, and I see you guys on Thursday.